I'm Benjamin Levy. I'm an associate professor at the Johns Hopkins School of Medicine, and I'm a thoracic medical oncologist. I'm also the clinical director for the Johns Hopkins Sidney Kimmel Cancer Center at Sibley Memorial Hospital in Washington, D.C. Should every lung cancer patient receive immunotherapy? Absolutely not. We're learning more and more about certain patients that just don't respond to immunotherapy. So there's really two broad categories that I look at when I think about who shouldn't get immunotherapy. The first is a patient with a pre-existing autoimmune phenomenon that would preclude that patient from getting immunotherapy. And this is where things get very tricky, because there are probably some autoimmune phenomenon that I would give immunotherapy, and there are others that I wouldn't. A patient with myasthenia gravis or multiple sclerosis, probably not going to receive immunotherapy if they have lung cancer. But a patient with mild rheumatoid arthritis, or even I have two patients this week with scleroderma that hasn't been treated in over 10 years, these are patients that I would consider, if they're eligible otherwise, to give them immunotherapy. So, and I'm talking mostly about advanced stage lung cancer, which is where immunotherapy is currently approved. The other subset of patients that probably should not get immunotherapy are certain patients that have genetic alterations in which we know, for reasons outside of the scope of this conversation, certain genetic alterations don't respond to immunotherapy. So patients with an EGFR mutation, we know, these patients usually don't respond to single agent immunotherapy. Maybe they respond to immunotherapy with chemotherapy, but they don't respond to immunotherapy. Same thing reigns true for ALK. Same thing reigns true for MET exon 14 skipping mutation. Same thing reigns true for ROS. These are patients generally, these types of genetic alterations that we identify in next generation sequencing, these are probably not the best candidates for immunotherapy, because immunotherapy generally doesn't work for these patients. In fact, the response rate to patients with ALK rearranged lung cancer as third or fourth line who receive immunotherapy as third or fourth line is around 5%. So we generally don't offer single agent immunotherapy for these patients. And this gets again to underscoring the importance of doing comprehensive genomic profiling, molecular testing, next generation sequencing. Those are all the same word on our patients, so that we know who's going to get a targeted therapy and who's going to get immunotherapy. So those are the two broad classes of patients that I think about through the prism of both toxicity as well as lack of efficacy.